the EMSNation podcast. I'm your host, Faizan Arshad. For the last episode in our World Trauma Symposium series, we have a very special treat. This is a highly evidence-based lecture from none other than Colonel Stacy Shackelford of the U.S. Air Force, who is the Chief of Performance Improvement for the Joint Trauma System Defense Center of Excellence in San Antonio, Texas. She has incredible contributions to pre-hospital trauma as well as tactical combat casualty care, and continues to lead on this front on the worldwide stage. Colonel Shackelford really digs into the evidence base of pelvic injuries, fractures, diagnosis rates, associated comorbidities, managements from impromptu MacGyver style to the commercial devices. There are a lot of nuggets and pearls in this lecture, so certainly tune in, take notes, and let us know and tweet at us what your favorite takeaways were from this lecture.
Thank you very much for inviting me. This is my first time here at this meeting, and it totally rocks. I have been working with the Joint Trauma System since about 2012 in the TC3 committee, and so it's really a pleasure to get an opportunity to present our work here reviewing pelvic binders. I cannot speak on behalf of the Department of Defense, Army, Air Force, or anybody like that. I only represent myself, and I also have to disclose that I really truly have no special passion for pelvic binders, but I do whatever Captain Butler asked me to do, and he asked me to review this topic. If any of y'all know Captain Butler, you'll know why. So why is this a problem? We did review the epidemiology of this, and it turns out that 26% of service members who died in the recent conflicts did have a pelvic fracture. On the civilian side, there's been some studies looking at hemodynamic instability in pelvic fractures, and if you're hemodynamically unstable from your pelvic fracture, that particular injury pattern has a 40% mortality rate. And even more so, open book fractures, the mortality rate is 48% with hemodynamic instability, which is important when you think about it, because that type of open book fracture, which is the most highly fatal from bleeding, is also the most amenable to compression with the circumferential device. If the pelvic fracture, it typically occurs from a severe blunt force trauma, so almost always has bad injuries associated with that, chest, abdominal, and long bones as well. And when we looked at the open pelvic fractures, most of those were caused by blast injuries, in particular dismounted blast injuries. Those wounds have a particularly high mortality rate of 68%. So this is recognized as a really big problem. These diagrams help to remind me of what I frequently forget, in that we look at a lot of x-rays and we can see the bones, but there's some very, very complex network of blood vessels that surrounds the entire pelvis. And in addition to the bones, you can see here on the front, from viewing from the front, there's some very, very strong ligaments that help support all of these bones. And from the back, these ligaments are very strong as well, and just wrapped around with branches of the internal iliac artery. And so highly prone to bleeding, and addition takes a lot of force to actually fracture that. Different mechanisms of injury on the civilian side in comparison to the military. So mostly on the civilian side, we see motor vehicle crashes, falls, and motorcycles, auto-peds. For the military, it's pretty impressive that 76%, 3/4 of them are actually caused by blasts. Gunshot wounds, 15%, and motor vehicle crashes, 4.5%. For the most part, if you're talking about pelvic fracture from a penetrating trauma like a gunshot wound, for the most part, that would not necessarily be something that could be compressed with, an external circumferential compression device of any sort. So mostly the ones that we're thinking about treating with the pelvic compression is actually the blunt force traumas. Treatment options. So really pretty much these are all options that you can do in the hospital, with one exception, right? So pelvic sling is the only intervention available pre-hospital, and given the fact that these fractures and pelvic disruptions can lead to a lot of hemorrhage. If you want to try to address this early at the point of injury, we're looking at the non-invasive pelvic slings. And what does it do? It can reduce pelvic diastasis. That's the open book fracture. It just helps close it, and that will help to tamponade low pressure venous hemorrhage. If the arteries are bleeding, however, you may not get good compression because the pressure in the arteries may push through that. So as we started looking at, do we want to recommend pelvic compression for the Tactical Combat Casualty Care guidelines? You know, it's kind of a big deal. Like, our guys are constantly like, you want us to carry one more thing with us? You know, our backpack's always full. We can't put one more thing in our kit. What do you want us to take out if you add this? You know, adding an additional recommendation to the guidelines is really, really a big deal. And in addition, you know, they don't want to be burdened with doing something that's not effective because it could waste time from other important interventions. So as we thought about this question, we said, well, are we going to recommend these binders? These are the questions we would want to know the answer to, and I'm going to go through them one by one. Starting with what term are we going to use for this device? Does a pelvic splint stabilize pelvic fracture? Does it control bleeding? Does it improve survival? Is there any harm when you apply the pelvic splint? Who should get it? What is the best type? And where does it fit into your resuscitation priorities? So terminology, I mean, it sounds kind of like a small point, but there's a bunch of terms in the literature: pelvic circumferential compression device, PCCD, pelvic orthotic device, pelvic splint, and the pelvic binder, which is a term that everybody constantly uses all the time, is now has been a registered trademark. And so, you know, especially you can see these guys actually have multiple different colors, you know, tactical for the police, one color for every combat uniform and every service, and then, you know, yellow for civilian EMS. So, you know, those guys that are out there, but, you know, so just choosing which term to use, I guess we're going to go with pelvic splint now since their lawyers contacted us about the pelvic binder term. So I'll try to stick with that. Does pelvic splint stabilize pelvic fracture? So this question is, you know, relevant just to see, does it do what it says it's going to do? And the only studies that I found out there looking to answer this question, they're all in cadavers. But there's 3 studies out there comparing different devices. One, the binder T-pod versus SAM. One, the T-pod versus just a sheet. And another one, T-pod versus sheet. Again, all in cadavers. They inflicted various unstable pelvic fractures in the cadavers, put the binders on, rolled them, did some torsion maneuvers, looked at whether there was any fracture motion with the devices on. And really, they did a very good job of stabilizing the fractures, and there was really no difference between any of the 3 commercial devices. And even if you compared the commercial device to just a standard sheet, there was no difference in the fracture motion. So as far as answering that question, this was our conclusion. There is evidence in cadaver studies that the fracture motion is stabilized with a pelvic binder. There's also one study that clearly shows that if you put the binder at the level of the greater trochanters or the pubic symphysis, that's the same level, then you get the best, by far the best, fracture immobilization. And so this just kind of shows you where that is. I think probably the pubic symphysis is the easiest thing to identify because the trochanters, not everybody knows where those are. So if you just kind of look for the pubic symphysis, and given that the fact that the binders are pretty wide, they should actually be centered at that level. And one study actually showed that 40% of the binders, that when they came into the hospital, they were placed too high. That's kind of like the most common thing, is people will put them too high. So you really need to emphasize that point when you train. Okay, second question. Does it control bleeding? Well, that turns out to be a little bit harder to answer because you can't really do it in cadavers. You have to find real live patients. We think, so what causes bleeding? For the most part, the main thing that bleeds is the posterior venous plexus, which is all around the sacrum where that fracture occurs, and the bone, when the bone is separated and those ligaments are torn. About 10% of the hemorrhage, however, is arterial. And that occurs from branches of the internal iliac, pudendal, superior gluteal arteries. And you can't actually predict based on the fractured pattern. You can't really predict very well. I mean, like an open book has the highest rate of bleeding, but any fracture pattern, literally any fracture pattern, can have life-threatening hemorrhage. So you can't tell just based on the x-ray whether they're going to have life-threatening hemorrhage. So getting back to the question of does it control bleeding, a couple of studies that are out there, not a lot of studies. This is one study looking at the effect of a T-pod in hemodynamically unstable patients, and it was really just a case series of 15 patients, and that study showed that they did improve hemodynamics, their blood pressure improved, and the heart rate improved from the time right before they put the binder on to the time right after they put the binder on. That was after hospital arrival. This is another study looking at the pelvic orthotic device, or no, actually any pelvic orthotic device, non-specific, to external fixation in 183 patients. Of note, this occurred after they got to the hospital, which you'll notice is somewhat of a concerning trend in all of these studies. They all occurred after they got to the hospital. So this particular study, they looked at the two options, and the patients who got just the circumferential device put on in the ED versus had to wait and go to the OR and get an external fixer, those patients who got the pelvic orthotic device did better. And you could see the improvement in mortality was 26%. Oh, sorry, that's mortality, which was non-significantly different, just a trend. But they did have less blood transfusions and shorter length of hospital stay. And really the authors suggested that because you could put the pelvic orthotic device on a lot sooner and a lot more quickly compared to the external fixation, then that probably helped reduce bleeding. So this is another study looking at civilian trauma patients in the German trauma registry, comparing a pelvic binder versus a sheet versus a C-clamp, which is a surgical intervention to pin the posterior part of the pelvis. And they found that the sheet had the highest rate of hemorrhage compared to the binder and the C-clamp, which were lower. So it did appear that the binder and the C-clamp did reduce bleeding compared to the sheet. And in that study, it was done in the trauma registry, they thought that, okay, yeah, if you compare the sheet to the commercial devices, it looks like the commercial devices are better, but as it also happens, our trauma centers are the ones that have the pelvic binders, and our community hospitals that aren't trauma centers, they're the ones with the sheets. So it may probably biased in that regard. So a couple of studies that showed reduced blood transfusion and lethal hemorrhage compared to other methods, probably a good bit of selection bias in those studies. And remarkably, in all of our searching, we could not find a single study of pre-hospital application of pelvic splints. And so we did see the couple of anecdotal studies where the hemodynamics did improve after applying the pelvic binder. So somewhat of weak evidence to support that bleeding is reduced. The million-dollar question, does the pelvic splint improve survival? And I'll tell you the evidence is even weaker in this regard. We found one study in the German trauma registry published in German. Had to get my German Army colleague to translate this for me. And they had 104 severely injured patients who had isolated pelvic fractures and hemodynamic instability. So pretty sick group of patients with isolated pelvic fracture. So, that is exactly the group of patients we want to study. They applied external pelvic compression to about half of them, and no stabilization to about half of them. And you can see the mortality was 19% versus 33%. So that's literally the only study I could find that showed any difference in mortality, but there was a mortality benefit in that particular study. Again, forgot to emphasize that compression was applied after hospital arrival. So there was one study in the US, it was a retrospective study looking at patients with and without pelvic compression. Again, I mentioned this was a trend, it was applied after they got to the hospital. And in that study, there was really no difference on mortality, need for bleeding control with angio, or their 24-hour infusion transfusion requirements. So that study in the U.S. showed no difference. Fortunately, there is a study that just recently started. It's registered on clinicaltrials.gov. It's called PATCH. I don't know if anybody here is involved in that, but I'm very much looking forward to the results of this study. It's actually a study of pre-hospital application of pelvic compression, and it includes anybody with severe blunt trauma and hemodynamic instability. And so that is, again, the group of patients we were wondering about. And I think, if you think about other things we've done for hemorrhage control, it makes absolutely no sense to wait until these guys get to the hospital to apply this intervention. And really, probably by the time they get to the hospital, the opportunity to really make a difference has already passed. And so I think this is really the answer we're looking for. So I'm hopeful to see what that trial shows. So very, very weak evidence that the pelvic splint may improve survival, but again, evidence in regard to pre-hospital application of the pelvic splints is truly, truly lacking. So if you see that, there's not a huge amount of evidence to support a benefit to this intervention. So it's really all it comes down to, like, risk versus benefit, right? So the next question is, well, it might be a little benefit. We think it will improve the stability and reduce bleeding and eventually reduce mortality, but are we going to hurt some people? And so there is some studies looking at that. This is a pretty good study, 115 patients with high energy tile B and C. And actually, I think my slides are a lot over tile B and C. And they looked at application of the pelvic binder in this group of patients just to see if there was, looking at the question of, was there any harm? And in 68% of those patients, they found that the x-ray got better. It looked better on the x-ray after they put the pelvic binder on. The x-ray looked unchanged in 21%. And then the fracture displacement on the x-ray actually increased in 11%, and those were the tile Bs, the lateral compressions. And when they reviewed all 115 of those patients, they really did not think there was any association between an actual damage to a vital or an internal organ based on the placement of the pelvic binder. So did not see any injury to the femoral artery, the bladder, or the rectal injury that was associated with placement of the compression device. And in some lateral compression fractures, the deformity did increase, but there's really no hazards associated. And I hear this quoted a lot, especially in the trauma centers, like, you don't want to put this binder on until you have an x-ray. You got to make sure it's not a lateral compression wound. You don't want to compress that acetabular fracture, et cetera, et cetera. But I don't think we have really any evidence to suggest that just compressing those fractures, they might look a little worse, you might get a little more fracture displacement. I mean, it's already broken, right? They're going to have to fix it anyway, so you may as well just take their hit on that. As far as harm, though, injuries to the skin can be a significant problem. You can get pressure injuries, just like any sort of pressure ulceration on the skin. If you leave it, probably it's not going to be a serious problem unless you leave it more than 24 hours. You do have to check the placement pretty carefully. We leave them on overnight in the ICU all the time for our really sick patients if we can't get them out of the ICU for other reasons. And so it's not really too uncommon for us to leave them on overnight once they get to the hospital. However, if you do get a pressure injury to the skin, it can actually delay your surgical intervention because that orthopedic surgeon is not going to want to make an incision through a skin ulceration, and that can affect their outcome. So it can be a serious problem if you do get that pressure injury to the skin. So it needs to be watched out for. So the conclusion we took on this, any harm in applying a pelvic binder, it's very unlikely to increase injuries. It's very unlikely to increase bleeding. However, you do need to watch out for pressure ulcers of the skin. So the next question is, okay, if you're going to put one on, who are you going to put it on to? The military data that we had, probably the biggest group of patients who was identified to have severe or a high incidence of pelvic fractures was the dismounted blast. So you step on an IED, And if you have an amputation, then if you have a unilateral amputation, 10% incidence of pelvic fracture, goes up to 30% if you have a bilateral amputation, and above the knee is as high as 40%. So very strong association with the pelvic fractures and the amputations. Specifically, this study was done in blast injuries. I haven't seen an equivalent study done just for all, amputations, but I certainly suspect that just the incidence of amputation alone can be highly associated with pelvic fracture. And that was one of the standpoints we took when we made the final recommendations for the guidelines. These authors, who were from the UK, concluded that routine applications of pre-hospital pelvic binders was supported in that patient group of dismounted blast with amputation. So we also noted that 14% of bilateral lower extremity amputations had open pelvic fractures, just for any mechanism of injury. The previous one I mentioned was dismounted blast, so bilateral amputations from any mechanism. And then if they had a perineal injury associated with their pelvic fracture, so it's kind of like an open pelvic fracture, that was 53% of the perineal injuries did have a pelvic fracture. Physical exam findings, these kind of, you got to look for them, right? But they're not super reliable as far as diagnosing pelvic fracture. But this is some things to look for. Pelvic pain, obviously. Any sort of ecchymoses, especially over the bony prominences, like the iliac crest or the greater trochanters. Ecchymoses on the perineum, scrotal areas, or blood at the urethral meatus, rectum or vagina with blood. Unequal leg length, you can definitely see. That could also be caused by hip dislocation, of course, but it can be strongly associated with pelvic fracture. And then we talk about the unstable pelvis. We always do it in our simulation exercise, but I don't know if anybody's ever felt one. It's it's hard to detect. So looking at civilian guidelines that are out there, the best one I found was, again, from the UK. Those dudes kind of rock when it comes to pelvic fractures, I guess. I don't know. But these pelvic fracture guidelines that they came up with in the Faculty of Pre-Hospital Care consensus statement is kind of like their group of EMS medical directors who came up with this criteria. And they suggested the following criteria: basically hemodynamic instability, which they defined with heart rate more than 100 or blood pressure less than 90. So any hemodynamic instability. If your Glasgow is low, you can't really get a good physical exam, so they included that. And then also distracting injuries, same like we talk about with C-collar, C-spine injuries, whatever. If there's another severe distracting injury, you may not get a good physical exam. So that was their recommendations. And then they did a really nice job of going back retrospectively and looking at all of their injuries in their trauma system for a 10-year period. And they found that 25% of significant pre-hospital missed injuries, I don't even like the term missed injury for pre-hospital, but unappreciated injuries in the pre-hospital environment was pelvic fractures, so about 1/4 of the injuries that they couldn't see pre-hospital. And of those, of the 170 blunt trauma patients in that series, there were 8 missed fractures out of 26 total pelvic fractures, and of those with severe pelvic fractures, 2 were missed. The ones that were missed typically had distracting injuries to the limb and head, and if they had used their criteria on the last slide, they would have caught most of those. So that was an interesting study from the folks in London. And so we took that into consideration, the dismounted blast, the mechanism of blast, and some discussion amongst ourselves. And these were the guidelines that we came up with as far as who do we recommend should get a pelvic splint. So any severe blunt force or blast injury, so we're really just talking blunt here, right? Not gunshot wounds, not penetrating trauma. Severe blunt force or blast with one of the following indications: pelvic pain, any major limb amputation or near amputation, any sort of physical exam findings. If you're unconscious, you had a bad mechanism of injury and you're unconscious so we can't get a good physical exam, and shock. And elsewhere in our guidelines, we define shock as altered mental status in the absence of TBI or reduced or absent radial pulse. So that's what we describe as shock. What is the best type of pelvic splint? Next question, we recommended, when we looked at limb tourniquets, we recommended 2 specific tourniquets because we didn't want crappy tourniquets on our battlefield, right? So what about pelvic splints? Well, turns out it's really doesn't seem to be any evidence to support one above the other. They've all kind of turned out to be fairly equivalent. You could have some individual personal preference among them. And even if you talk about improvised splints versus the commercial devices, really no evidence to necessarily support that the commercial devices are better than the improvised devices, although I'll show you a little bit more details on the improvised devices. This picture also kind of illustrates one other important point, that if the legs are flopping around or rotating, externally rotating with the feet, then that also causes fracture motion and increases bleeding. So you do need to do something to kind of control that motion there as well. So when we looked at what is the best type of pelvic splint, honestly, I don't want to go into too much details, but really all of these devices, whether we're looking at the issue of fracture motion or the issue of lethal hemorrhage or time to apply it, etc., there really was nothing that led us to select one device over the other. There was that one study that I mentioned earlier in the German system where the patients that were transferred with just a pelvic a sheet wrap had a worse outcome, but again, it had a big confounder in that study coming from the non-trauma centers. So we thought there was very weak evidence to support that a commercial device is more effective in controlling hemorrhage than an improvised sheet. So, and again, in our environment in the military, it's always an advantage if you don't have to carry something else in addition to what you already have in your kit. So we were pretty reluctant to say that improvised devices were not recommended or to strongly recommend the commercial devices. However, it is important to note that whatever you use, you have to literally train on. And so it's not like you're just out of the, when we say improvise, you're not just going to improvise on the spot and try to figure that out. You have to have a plan for it. What's going to be my pelvic binder? That's how I'm going to train, and I'm going to know how to do it correctly. Where does it go in the priorities? This is where we put it. So as far as March, massive hemorrhage should all be external. But under circulation, we said we're going to prioritize anything that stops bleeding over any type of resuscitation. So pelvic binder, we put it first as the first circulation as the first intervention under circulation, as well as reassess tourniquets, and then you move on to IVs, TXA, and fluid and blood product resuscitation. What is the best placement? If you put it over the clothing, you may not get accurate positioning, and once you get to the hospital, you're going to have to take it off and put it back on again, which is going to cause more problems. So best idea is to put it directly on skin. I know that's not always possible, for sure, and especially in our environment, you may have to put it over the clothing. If you can put it on before you really move the patient too much and trying to avoid log rolling them too much, it's much better. So just anything you can do to reduce the fracture motion. Secure the legs, because the legs moving around is going to contribute to the problem, and tape the feet together. So I'm going to just show you a couple of just learning points on the different devices. So SAM pelvic sling here. This device is the narrowest one from top to bottom, which I think may have some advantages if you're talking about using it in conjunction with Reboa, which is getting more and more common. If you pass it around behind the thighs and slide it upwards, it typically reduces the chance that it will be placed too high, so that is also recommended. And then this device has a counter traction that everybody forgets to pull. You got to pull the counter traction, otherwise it just slips around sideways, and then you Velcro it down, secure the feet. T-pod, this is the T-pod and the pelvic binder are kind of similar because they both have these big lacing systems. It's pretty wide. You can cut this one, though, for Reboa placement as well. This one, it's got this big wide Velcro. Slide it up. Make sure it's centered over the pubic symphysis. And in their manufacturer's instructions, it shows cutting this, but you can also just fold it. I think most of the time we just fold it because it's harder to find the scissors in time, and then stick this Velcro down and pull it tight. You got to make sure there's pretty good separation right here because it'll reduce it quite a bit. And then again, secure the ankles, or you can put tape around the toes, one or the other, just make sure they're secured. And pelvic binder device, pretty similar to the T-pod. Again, goes around, same thing at the level, greater trochanters, pubic symphysis here. And you Velcro it down and pull the laces tight, secure the ankles. So a couple of things about improvised. If you're going to tie a sheet around the waist, you can't do that with one person. Like, there is no way, I don't care how big and strong you are, you cannot keep that thing tight and tie it in a bow at the same time or not, whatever. You can't do it. So you have to have two rescuers, which is different if you think about this, the commercial devices, that could be done with one person, right? So this one will, if you're going to use a sheet, you got to have one person hold it tight, or two people pull it tight, and then one person hold tension while the other one figures out how to secure it. I think the best thing to use to secure it is actually zip ties. I know a lot of people use zip ties for multiple purposes, and they're super good for holding stuff down. So nice thing to have with you, especially if that's your plan to use a sheet. Or you can also cut the trousers, which this one seems to be popular as well. You can cut the trousers and wrap those around, secure them with a zip tie the same type of way. Or this is just showing like using some big broomstick, like you're going to really be able to find one. But we actually tried doing this with the rifle, and the OPSEC guys didn't think that was cool. So, but you can use your rifle as a windlass if you want, and then secure it with the tourniquet. The tourniquet, this should not be tight right here. It's just holding it. But none of those methods, like these other improvised methods, there's a really pretty cool one with the SAM splint and a limb tourniquet that you can use. None of them have really been studied, but I think they all they're similar enough to the pelvic sheet that they're probably about the same. So this is my final slide, and I just kind of want to emphasize some training points for those of you that are doing this and those of you that are training people to do this. So very, very strong point of emphasis. Make sure you put the binder at the level of the greater trochanters, which is also the level of the pubic symphysis. Try to avoid excessive movement of the patient until the binder is placed. Even after you put the binder on, try to just not really log roll them, or not log roll them all the way onto the side. Like when we put them on a litter, a lot of times we'll log roll them all the way onto their side. Maybe you could get by with just like a 30-degree log roll instead of a 90-degree log roll. Try to keep that fracture motion minimized. If you put the binder under the thighs, you have to either put it under the thighs and slide it up, or put it under the lower back and slide it down, because it's pretty hard to put it right under the gluteal area, because you have to pick the patient up. So if you put it under the thighs and slide it upwards, it's just a lot less incidence of it getting positioned too high, and so that was a recommended technique. Secure the ankles and the feet. Don't let those flop around and cause further injury as well. If the improvised pelvic binder is the plan, it has to be trained. So train with what you're going to use. Don't just improvise it on the fly. And keep in mind that the improvised technique, it could be highly variable from person to person, and it does require at least two people to do that correctly and to maintain tension. In a better plan, we have also recommended junctional tourniquets in the guidelines, and there's a couple of circumferential junctional tourniquets that go all the way around and work perfectly good as circumferential pelvic compression, and they also have the extra added benefit that they can occlude the femoral artery in order to stop hemorrhage from the groin area. So that could be a dual purpose solution right there.
Thank you guys so much for tuning in and for your support of the EMS Nation podcast. We very much appreciate you listening in and making the conscious decision to upgrade your skill set and deliver the highest quality care to your patients. We also value your feedback and would love for you guys to leave a review on iTunes so that we can continue to share this podcast with all the pre-hospital colleagues on this planet, and let people know, regardless of what your favorite listening style is, we are available on iTunes, the Android platform, and we also recently joined Spotify. So please tune in to the next episode of EMS Nation. Here is a salutation from the Pre-Hospital Trauma Committee of the National Association of EMTs.
I'm Andy Pollack, medical editor for PHTLS 9th edition. My full-time day job as chairman of orthopedics at the University of Maryland, but I'm also the medical director for the Baltimore County Fire Department and a special deputy U.S. Marshal. I can tell you that we are clearly looking forward to the upcoming publication of the 9th edition of the PHTLS textbook. Our authors have been hard at work editing the prior version and adding new content to ensure that we have thorough coverage of all the topics that are important to pre-hospital care providers at all levels, and that we've clearly established the evidentiary basis for the statements made and the conclusions drawn. We'll be rolling out the new edition at the World Trauma Symposium in Nashville this coming October, and we hope you can be there for this exciting event.
My name is Jesse Bidlow. I'm an anesthesiologist and EMS physician from Switzerland. I'm in charge for the airway chapter of 9th edition of PHTLS. Actually, I think it's very important because there has been a lot coming out in the last years about airway management, and not only in advanced airway stuff, but we have come to recognize the importance of basic airway management. So we have a lot in store, not only for big-time ALS providers, but for each and every EMT on the street. So I'm very, very excited about this 9th edition we're going to present in Nashville.
I'm Alex Eastman. I'm the medical director of PHTLS, and it is a real pleasure to follow in the footsteps of some giants and friends who have filled this role before me. The theme for the 2018 World Trauma Symposium is New Threats, New Solutions. And at a time when the world seems a bit uncertain, when EMS providers are being asked not only to face novel threats but to respond to them, we felt like it was our responsibility to bring a conference together that helps not only introduce the 9th edition of the PHTLS program, but brings you, the EMS provider at all levels, a better ability to respond to the novel threats that are out there. So I hope that we will see you in Nashville. We'll promise you an unparalleled program that I think you'll enjoy. So with that, I'd say thank you for listening, and we'll look forward to seeing you in Nashville.
This is the Pre-Hospital Trauma Committee wishing everyone a safe tour.